This is Andreas Kamal from HSS narrating our technique of combined all-inside ACL reconstruction together with the tibial anterior closing wedge osteotomy for slope correction in those patients that have repeated ACL failure with increased posterior slope. In terms of graft choices, I tend to use quad tendon because it gives you a nice sturdy graft. The technique for the HTO can either be above the tubercle or, as I'm showing here, below the tubercle. You can reuse pre-existing incisions, for example, from a prior BTB tendon harvest, but the incision should be roughly midline because you need to approach both the medial and the lateral aspect of the proximal tibia. This shows you the incision along the anterior medial tibia, opening flaps, exposing the pes medially. We mixed videos from an actual clinical case with a cadaver lab. I mobilized the pes to expose the MCL and then I undermine the superficial MCL. Just want to mobilize it enough that you can bring retractors underneath. Once you have the medial side, then you switch over to the lateral side. This is very similar to a TTO approach where you take the muscles of the anterior compartment off the lateral tibia. In terms of concurrent ACL reconstruction, obviously this is a technique that you can do both concurrently or in a staged fashion. For example, if you have very enlarged tunnels, you can use bone graft harvested during the closing wedge osteotomy and utilize this to graft your tunnels. Here in this clinical patient, the tunnels weren't enlarged too much, so this was amenable to a single stage revision. I'm marking here the tibial tubercle. This is an infratubercular HTO. I place one pin. I measure the length of the pin to the posterior cortex to protect the neurovascular bundle. Then I mark the closing calculated on pre-op MRI scans. In this case, it was about 1 centimeter of a wedge. 5 centimeters is the length of the intraosseous pin placement. And then I mark on a saw blade the length to give me an extra visual reference of how deep to go. You have a retractor under the respective structures. Here again, marking the depth. You want to make sure that you don't penetrate through the posterior cortex to protect the neurovascular bundle. The second cut is slightly angled. You aim roughly for the level of the waist of the fibular head. You remove the wedge. You can use that for bone graft if you want to do a two-stage revision. I finished the osteotomy with an osteotome. If this doesn't go easy, you want to revisit your osteotomy gap with small pituitary ruptures. You do a hyperextension moment to close the gap. Then my preferred technique is one compression screw that goes roughly from the tibial tubercle. So you split the patella tendon, you aim distally, that gives you compression. And I use 4-5 screws. First 4-5, then a 3-2 drill bit, put the screw in, compress, and then these are staples. I use 2 staples, one medial, one lateral to the screw. The procedure is done with a large C-arm, mostly using a lateral view. These are the final fluoroscopy pictures from the OR where you see the compression screw, the 2 staples, and then already a button for the ACL reconstruction. What I find especially useful with the infratubercular cut is that you can get the osteotomy done and the ACL reconstruction on the tibial side is completely above and there's no hardware interference. This shows you the typical tibial aiming guide and you can see how this is proximal to the osteotomy cut, and that essentially makes this a normal ACL reconstruction with whichever technique you prefer. In this case, an all-inside reconstruction. Post-operatively, I have these patients protected weight-bearing on crutches for 4 weeks in a brace. Advanced weight-bearing is tolerated. Hope that you find this helpful. Take care.